Good morning, everyone, and although it's a bit late to be saying it, I'll say a Happy New Year to everybody who I haven't already seen this year. Welcome to the first 2026 meeting of the Integration Joint Board Performance Audit and Assurance Committee. This is hybrid, as you know, and there are a number of people on screen, and it's also being live streamed. So without further ado, we will begin with the first item on the agenda, which is apologies. Do we have any apologies today? No, I'm told we have no apologies. Everyone's New Year's resolution. Do we have any declarations of interest? No declarations of interest. In that case, we'll go on to the minute of the meeting of the 21st of November. Just trying to think back to when it was. Do we agree that as a correct minute? And are there any matters arising from that minute? So we agree it is a correct minute and there are no matters arising. Okay, so we'll move on to the first substantive report on the agenda. Oh, sorry, no, I've got the action log to cover, which I don't have because there isn't one. There are no outstanding actions. So I don't think we need to agree anything there. We move on to the Integration Joint Board Strategic Risk Register, and that report's going to be covered by Ewan Murray this morning. So thank you, Ewan. Go ahead.
Thank you, Chair. The updated Strategic Risk Register presented to committee today is in the familiar format, still in essentially a light touch review, whilst the work that I have described in the covering paper around updating the format of the Strategic Risk Register and taking the opportunity while doing that to perform a couple of the outstanding focused reviews of strategic risks proceeds. The number of live risks and
could I just ask you to get the microphone a little closer to you? I should have commented on the fact that we've got different microphones this morning. When you first press it, it will go green, and when it's a bit counterintuitive. It's when it goes red that you can speak into it. And if you could make sure that you are close enough so that it's being heard by everyone. Thank you.
Thank you, Chair.
Sorry for interrupting.
As I say, it's a relatively light touch review at this stage. We are continuing to append the Children and Families Corporate Risk Register for information and completeness, pending the finalisation and approval by Scottish Ministers of the integration scheme. But by the next meeting, you will start to see a revised format of Strategic Risk Register, which is hopefully improved and easier for members to digest and get a clear and almost instantaneous appreciation of the strategic risks. And risk will be, in terms of the risk register, will of course be a dynamic process going forward as we go through the process of preparing and agreeing a revised strategic plan. There'll be a need to continue to review the strategic risk register through that process to make sure it reflects the strategic risks of not delivering against the strategic plan. Thank you. I'm happy to take any questions.
Thank you, Ewan. I suppose we should be pleased that at least none of the risks have got even more risky, but sad that none of them have got any better either. And obviously the financial sustainability remains very high as an issue on the risk register. And although we don't know yet the details of the the settlement in terms of the budget decisions on Wednesday. It doesn't look like there's going to be any great good news there. However, David.
Thanks very much, Chair. You used a term there. I wonder if you could explain it a bit more detail. You said your response was a light touch review. Given the severity of the issues that are on the register, what did you mean by a light touch review?
Thanks for the question. It just means we've kept the current format of the strategic risk register and updated any elements within it that we saw needed updating since presentation to the last committee meeting. That kind of more fundamental review is going on in the background, and that's what will come back in our next cycle.
Thank you. Thank you. Any other questions or comments? Yes.
Okay, this is now working. So it's two comments then. First one is on SRR3 around partnerships, and it's probably a more systemic piece about how we manage risk. When I'm looking at this, we've got a deviation between our current risk score, what our target risk appetite is, and then if I look at the actions and the further controls required, I've got an awful lot sitting there that's just ongoing. And I think in terms of control and assurance for this committee, I would really like to see some specifics there, because what we should be seeing is, are we taking the action, is it completing, and is it making a difference to the risk? And I think when they're so general that we've got ongoing, we're unable to do that as a committee. So it's just, as you're going through that risk review, it's, can we get these as specific and timely as possible? And yes, they might not do what they need to do, but at least then that prompts that action to have a look at it. So that was the systemic piece. And I think when you look at some of those, you think, well, actually, do we have the right additional actions in place to be able to mitigate the risks? And when I looked at SRR3, I looked at that and thought, it doesn't look there that the actions are going to give us a sustainable way to be able to get the current risk level down into appetite. And I think that's what, as a committee, we really want to see. So what is the from the two, and if we're not going to make that, for example, with the financial sustainability risks, I think that's almost an acceptance from the committee rather than a just walk on by.
Okay, thank you. Yes, Ewan.
Thank you. Those are helpful comments, and happy to reflect on those as I'm updating the strategic risk register. There is some for me just around the principle of the things we say we're going to do and actions being smart. So happy to take that on board.
Yes, I think it's important. Sorry,
I was just going to say what you.
Oh, okay, Mary. Yes. No.
Yeah, I guess it was just to acknowledge your comments as well, Alison, but Ewan's obviously covered it there. But yeah, that review that's going on in the background will definitely address it. I think when you see the updated format, some of those actions will be coming through, and you know, it's busy. It's very busy at the moment, the document that comes to the committee, but I suppose it's about making it more succinct, making sure that risk appetite is recognised, and that, as you say, that those further controls required are absolutely relevant, and one measuring against how we're performing against them as well. So, but Ewan's kind of covered that as he spoke. Thanks.
Yeah, thank you for that. I think it is important that we not only kind of record the risk, but also look at what we're doing about it, the positive ways in which we can move forward. Any other questions or comments? I see no hands, so thank you. Just get to the recommendations. So the recommendations are that we should consider and comment, which I think we have done. Consider and comment on the detailed register and appendix. Note ongoing review of the strategic risk register, and that a revised format will be presented to the March meeting. Note the continued inclusion of the Children and Families Corporate Risk Register to provide overview to the committee pending finalisation of the integration scheme. Can we agree these recommendations? I'll take
Agreed.
silent. Agreed. Thank you. And we look forward to a revised format. And of course, if others have thoughts about ways in which it can be improved upon, you would be more than happy to accept any comments sent directly to them. Okay, we'll move on then to the governance report, which again I think is you, Ewan. The governance statement, improvement actions.
Thank you, Chair. Governance statement improvement actions report is presented in the usual format today and continues to be updated on an ongoing basis. I would expect, we've obviously got the issue around the outstanding approval of the revised integration scheme, and then taking that into account when that is approved, we'll see change in terms of the content, and also taking account of the conversations we've just had around risk. We'll start to see that content really move in the next cycle. I would hope, albeit we are not completely in control of the timing around, or we're not in control of the timing around the Minister's approval of the revised integration scheme. So we will continue to update as appropriate the Monarch report to allow the committee to perform their scrutiny and assurance role. Thank you. I'm happy to take any questions.
Thank you, Ewan. Just first of all, I mean, do we have any update on where the approval process is for the integration scheme? I think Gail might be the best person to come in on that one.
Yeah, so just to confirm that the refinements are still ongoing, and we do hope to submit to Scottish Government fairly soon, over the next couple of weeks or so.
Thank you, Gail. It just does seem to be taking longer than anybody would have liked it to take, but I suppose these are the ways things go. Does anyone have any other questions about the governance statement improvement actions? David?
It's a simple question. It's on reference 1, progress of the integration scheme. The first paragraph about medical staffing, I read it 2 or 3 times. I didn't quite understand that paragraph. I just wonder if we could have a further explanation of it. It's probably I only read this last night, having returned from leave, so my apologies. I just found that difficult to understand.
I think Marie might be best to answer that one.
So I suppose that's around, it's quite a legacy statement, that one. So it's around the transfers that happened around the original transfer of budgets when they were being delegated. So there was due diligence exercises outstanding for some time around making sure that appropriate budgets had transferred. There was, for a number of years at the start of IJB integration, there were a lot of questions around whether the budgets had been appropriate, if there were overspends in place, and so that due diligence exercise had been ongoing for some time. For me, with the update of the integration scheme, we can take that action off. There are always going to be questions arising as we go through our budget monitoring process in relation to all of the delegated budgets. There's always questions around what was the legacy, around the original budgets that were transferred. And we do have kind of ongoing conversations with partners around, was it the appropriate budget that was transferred? Should we be looking at changing that? But for me, this long into arrangements, we have the budgets that we've got, and we have those ongoing discussions with partners around what's appropriate and what's not. For example, I'm just thinking about one, and I know it's not specific to that comment, around the PSAP arrangements. So the PSAP budget, we have conversations fairly regularly about at the IJB. There is an overcommitment there. So there's that question around, did we get appropriate budget transferred over? So those conversations continue with our partners on an ongoing basis, and we build in any shortfalls, etc., into pressures for the budget process. So when the integration scheme signed off, I would see that as a legacy comment that's going to come off. So I hope that helps.
Thank you.
Thank you. Maybe just PSIP.
Sorry.
PSIP. Can you explain PSIP
Oh, sorry.
for everybody?
That's the Primary Care Improvement Programme. So that's money that came from the government to free up GP capacity. So it's putting in those things in GP surgeries that free up GP time to concentrate on those more complex cases for GPs. I don't know whether Tom might want to come in. So at the moment, there's a bit of an overcommitment on the budget. We're just trying to understand the full extent of that. And obviously that perhaps more relevant for the IJB when I bring forward the next budget update. But we're having conversations around that at the moment and how we might bring forward options to make that more viable. Thanks.
Okay. You have anything to add, Tom? No, that enough. It's enough. Okay. Right, thank you. Roger?
Thanks, Chair. I think the question there was pertinent, that we really do need to speak in plain English. And I I understand that because I've been here for a long time, but only because I've been here for a long time. I'm not surprised reading it again that somebody new wouldn't have understood that. So please, plain English.
I think that's a plea that comes quite often from a number of sources. People who are immersed in it tend to forget that everybody doesn't understand all the terminology. Any other questions, comments? In that case, the recommendation was to comment and agree, consider and comment and agree. So can we agree? Agreed.
Agreed.
Okay, thank you very much. We'll move on to item 7, which is National Reports and Inspections Overview, and that's on page 57 of the agenda. And I think that is Marie going to pick that up, and possibly Nicola.
Yes, thank you, Chair. I'll make a start and then I'll bring Nicola in when we get to the Care Inspector and the Mental Welfare Commission reports. So this is the overview of National Audit, Scrutiny and Inspection reports published since the last PAC committee on the 21st of November. There have been 2 Audit Scotland reports, 2 Care Inspector reports and a Mental Welfare Commission report. And we're presenting them in the paper today. So for the 2 national reports, there have been 2 Audit Scotland reports published. The first being Falkirk Council's annual audit report for 24-25, and the second being the report from Audit Scotland on NHS in Scotland 2025. These have been circulated to members separately anyway, but some of the key points are in the paper. So for the Falkirk Council annual audit, it was issued on the 15th of October 25, and the report showed that the audit opinion was unmodified and that some adjustments had been made as a result of the audit process. Obviously, the members on the board who sit with council as well will have seen this coming through council committees. The wider scope audit showed that the council had effective and appropriate arrangements in place for financial management and financial sustainability. The council operated within its budget in 24-25 and achieved 94% of its planned savings, and the reserves balance reduced by 14.9 million during the year. The report also noted that the council had the second highest budget gap as a percentage of its revenue budget, and that arrangements were in place to address this. It also noted that the council had effective arrangements in place for securing best value, and some of the audit recommendations are set out at 4.9. Around the Audit Scotland for NHS in Scotland report, it was published on the 4th of December 2025, and some of the key messages are set out in 4.11, with health spending totalling 20.6 billion in 24-25, being 37.5% of the overall Scottish budget, and the NHS in Scotland stating that the NHS in Scotland was not in a financially sustainable position, with spend projections continuing to grow. The recommendations are set out between 4.13 and 4.16 in the paper, and I suppose just to pull out one, and specifically in relation to IJBs, at 4.16 it noted that in 24-25 8 billion of NHS board funding was delegated to integration authorities, being 47% of their overall revenue budgets. The Health and Social Care Service Renewal Framework sets out a strategic commitment to shift funding from acute to primary and community health services, and this includes moving more staff funding funding and services into local areas. And I suppose we've seen some of that this year for ourselves around that shift in the balance of care project, and some of the conversations we're having around what might primary care do and community care do more. So we're just definitely looking to do more of that in the future. So I'm happy to take any questions on that first section, and then I'll hand over to Nicola for the inspection reports at 4.17. Thank you.
Thank you, Marie. Yes, those of us who are on the council will have seen reports. But it is useful to have them included in the papers for all members of the Integration Joint Board. So thank you for that. Does anyone have any questions or comments that they want to raise on this? No? I see no hands. But I think it's a kind of statement of the position as is. I think it does highlight the financial difficulties which we're all aware of. And so it's not just the IJB that has a financial challenge, it's the partners as well have financial challenges. So sad but true. So thank you very much for this report. We are asked simply to consider and comment. Oh, sorry. Oh, sorry, we've got Nicola's section. I apologise. Nicola. That's the more fun bit as well.
Thank you. So the inspection part of the report, you'll see that there's been 3 published inspections since the last report. The first one is a Mental Welfare Commission inspection that relates to wards 2 and 3 in Forth Valley Royal Hospital, which are mental health areas. You'll see at section 4.18 that there are 3 recommendations that's been returned from that report. This report relates to a service which is managed through Clacks and Stirling Health and Social Care Partnership governance purposes and arrangements, so they will take the improvement plans through there. Just to highlight though to committee members that I have had a conversation with the Chief Nurse for mental health services in relation to some themes that we're seeing coming through reports, and she has given assurances that those themes are being picked up and managed appropriately, so I just wanted to share that additional assurance. The second inspection report is a care inspectorate report that relates to Burnbrae Care Home. They were visited in November. You'll see at section 4.21 that they were inspected against 3 key questions, and they returned ratings of 1.6, which is excellent, and 2 5s, which is very good. So it was an overall very positive visit. The care inspectorate actually documented in the report that Burnbrae Service demonstrated sector leading practice and highlighted that they're delivering outcomes through person-centred care plans and creative approaches to promoting mobility and independence. They praised the staff for being responsive. They highlighted that dining experiences were dignified and supportive, and they also made positive comments around a quality improvement project that was undergoing to reduce falls. There were some minor areas for development noted, and they'll be picked up through improvement plans that will be monitored through the Clinical Care Governance Management Group. The third inspection report that's been published is the Care at Home Strategic Inspection. So the Care Inspectorate carried out a test to change inspection in Falkirk between the months of April and September in 2025. So this was a test approach to inspection, and it sought to identify one sort of key question, and it was how effectively were the Health and Social Care Partnerships commissioning arrangements contributing to good outcomes for people and carers. So you'll see from the report that the approach incorporated 27 inspections of regulated care at home services in Falkirk, and that includes surveys with people experiencing care, family members, staff surveys, and sampling case files as well. You'll see that there was some key strengths identified within the report, and that included positive outcomes for almost all people who received a care at home service, effective strategic commissioning arrangements. It highlighted that there was collaborative multi-agency leadership visible, and that person-led care practice was demonstrated by staff. At 4.27, you'll see that there's some areas for improvement identified, and that includes self-directed support, carer support, hospital discharge pathways, performance frameworks and transformational change. But overall, all of the elements of the inspection were graded as good, and the partnership will consider the findings and prepare an improvement plan. Again, locally that will be overseen and approved by the Clinical Care Governance Management Group, but will also be overseen by the Care Inspectorate. So I'll stop there, but happy to take any questions.
Thank you. Just one of the issues that arises for me is kind of the things that keep coming back, as opposed to, I feel as if when something is highlighted as an improvement action required, then one would hope there is an improvement action and we don't hear about it again, but that's not the case. Could you maybe comment on that? First of all, in terms of the Royal Hospital.
Yes, so in relation to recommendation 2, is that the part that you're, so recommendation 2 is in relation to the psychotropic medication being legally authorised, and that's in relation to when somebody in hospital is receiving medication that they don't have capacity to give consent for. There should be a separate treatment form that's signed and in the notes, and unfortunately when the Mental Welfare Commission have visited certain areas, they have found that there's been occasions where that hasn't been the case for one or more people. What has happened, so we've seen it coming through as a theme in this report, because the Mental Welfare Commission are visiting different areas and they're finding that, and so it's not that they've went back to the same area and the same issue has arisen, but what probably needs strengthened is other areas taking learning from visits that's happening in other areas. So this was in wards 2 and 3 in Forth Valley Royal, and that's why I had the discussion with the Chief Nurse for Mental Health. So she's assured me that the learning from this, they have picked up the theme, and there is a focus group looking at how they share that learning and ensure that the improvements are made, not just in the area that's been inspected on this occasion, but in all the areas that this relates to.
Thank you. And I wonder if you could say a wee bit more about the training, because there was a recommendation that staff should be trained for the promotion and recording of advanced statements. Is that part of what you've just been talking about, or is that additional training?
That's separate, yeah. So it's good practice that people are supported to have advanced statements. So if on the occasion that they do become mentally unwell and they lack capacity, then there's an advanced statement that describes what their wants and wishes would be if that situation arose. But this is a national issue across Scotland. Advanced statement completion probably isn't at the level where we would want it to be, so they've picked up that if more staff were trained in that, then we might be able to improve that compliance. So it's a slightly separate issue, but it's been picked up.
Thank you. In relation to the care at home strategic inspection, it's mentioned that this is combining elements of the regulatory strategic inspection methodologies and using bespoke quality framework. Is this a new approach that we have not seen before? And could you maybe say a wee bit more about that?
Yes, it is a new approach, and they were testing out that approach in Falkirk. But I see Caroline's online,
who's going to come on
more heavily involved than me, who'd be able to describe it far more eloquently.
Okay, Caroline.
Yeah, thank you, Chair. So yeah, this was a new approach. So it's the first time it's been done in Scotland. And what it was trying to do was kind of triangulate information from regulated inspections, along with that kind of strategic partnership arm, and look at across the services. So also considered services that were provided from private providers, as well as our own in-house care at home, along with our partnership services. So yeah, it was a really positive feedback that we got around the inspection.
Okay, thank you very much. I've got more questions, but I'll not hog it for now. So Alison.
There we go. Okay, we're there now. Okay, so I've got 3 points. The first one actually builds on your point, Councillor Hannah, which is about that thematic element of it. And for me, it would be really helpful when we do have these updates on the inspections of review, that we actually take that back into a thematic review as well, so that we've got almost that running view of the themes that are coming out, because we should be tracking the themes as well as the individual action plans. And I would expect that to see that kind of running through the governance. So it's just an ask that when we are getting individual elements, we do that piece into and the theme and then what that looks like, and we tie that into the action plans. The second point was about the Burnbrae report, and that really brought a smile to my face actually when I read it. So first of all, just commendations to the staff for such a good service delivering. But it also prompted the thought in my head that audit and inspection reviews aren't just about finding problems and giving us assurance, they are about identifying that good practice. And it's just how are we systemically taking that good practice and making sure that we don't just have one excellent centre, all of our centres are operating at that same level. So how do we take the good practice? And then the third one is about the care home strategic assessment. And as a board member, when we're doing those innovative, slightly more transformational initiatives, I think it's incredibly helpful to have that third party oversight, because it gives more confidence that actually we have got that assurance that it is working when we're making major changes to a system. So I think I think that's a really positive thing. The challenge, I think, when I read that, again, we're back at systemic issues, was the comment made about transformation change not at required pace. Now, this was something we were doing as a test of change, and we did lots of things we wouldn't normally do, but there's still a call out that we're not making the transformational change at the pace. That does concern me when we look at what's coming ahead in the next couple of years. And the question back is, okay, how do we address that? So lots in there, I'm afraid.
Thank you. Thanks for your comments. And you're absolutely right. They're really helpful. So we'll consider them moving forward and make sure we pull out the themes and the learning. Thank you.
Thank you. Does that satisfy your comments? Yeah. I think Roger was next and then Stephen.
Thanks. Just on the Burnbrae issue, as you know, I go into quite a lot of care homes in part of my job, and I've been going into Burnbrae a few times recently, and it was so refreshing to go in there compared to so many of the other homes I go into. It was a step above the care that I see in so many other care homes. The staff all were welcoming. They all knew the residents really well, and were helpful to me. It really was a difference, and so I want to congratulate the staff in Burnbrae for and the inspection, which followed what I would have said as well. So thank you to everybody in Burnbrae.
Thank you, Roger. Stephen?
Thanks, Chair. I had a few points, most of which have been covered. So my final one was just, I suppose, how do we get ahead of the game in some of the inspections? So about being cited in any near misses or any early warning signs that might get picked up. What's our kind of process in that? Thanks.
Yeah, so through the Clinical Care Governance Management Group, we do look at themes across all of the areas. So we look at adverse events that's been put in, we look at care inspectorate notifications, we look for emerging themes that require improvement work. What the teams also do as well is they identify areas for improvement themselves, and you can see that's been highlighted through the inspection report in Burnbrae. So we're not waiting for somebody to come and say you must improve on this, we're highlighting it ourselves and actually taking the initiative to pick up quality improvement projects that are then highlighted as good practice when inspectors come in. What we probably need to build on is, that learning from other inspections, not just locally, but nationally as well. So actually having one eye out to see what inspections are picking up elsewhere, to see if there's any learning from us. And that's something that we can take forward this year to try and get a process in place in terms of how to do that. It happens probably ad hoc, when we see cited different things, but we probably need to pick up a more systematic way of doing that. But that's something we can pick up this year and see how we strengthen that.
Thank you, Nicola. I said I did have some more comments, and of course, because I brought in others, some of those comments have been stolen from me. But there you go, by others. But I think in terms of Burnbrae, you made reference to the work that was commended on Falls, and I think that is an example of something that has been a lesson from one care home brought on to another care home, because that, as I recall, started in Grahamston House. So I think that I wonder if you maybe just say a wee bit more about it, because I think that really is a fundamentally important piece of work.
Yes, absolutely. So the quality improvement project to reduce falls within internal care home settings, you're right, started in Grahamston House, and it was part of a wider safety collaborative that was ongoing across Forth Valley, and it was including health and social care teams. And the project in Grahamston did various tests of change, and it looked at improving physical activity within the residents and incorporating visiting times and things. So it was a whole approach that included carers as well. And the results of that were quite remarkable. So when the processes and things were refined in Grahamston, that model was then picked up and spread out to other internal care homes, including Burnbrae, which is what the Care Inspectorate's obviously seen as well in terms of that spread. So, whilst there's some areas that we need to strengthen in terms of learning from other areas, you're absolutely right, Chair, to highlight that as an area of good practice that we're spreading learning across our other settings.
Thank you for that, Nicola. And I think I'm right in saying there's actually a video on the website from the Grahamston House exercise. So I think I would recommend it for people to have a look at, because it's another one of those things that brings a smile to your face. So Roger and then Alison.
Thanks, Councillor Hannah. Just on that subject of the exercises to reduce falls, understand that the housing with care complexes also were doing exercises to reduce falls, but obviously Tigasaw is no longer going to be able to do that. Is it something that we should be looking at continuing Tigasaw for those residents there to reduce the falls there after the changing of the way care is provided there?
I'm not sure about that one. I'm wondering, I don't know if I don't want to put Caroline on the spot. I didn't realise it had spread to housing with care, which is obviously great. But I don't know what the setup would be with the change in tickets.
Caroline, are you able to say more?
So what I would say is, in terms of what we've done in other areas, other so residents that perhaps in other accommodations, the residents themselves have organised. There's community groups that come in and do active activities, and they're the type of things that we'd be looking. So it's actually community development that's supporting the tenants, and not just within Tigasaw, but in all housing with care complexes. Because again, within this model, the care that's delivered is about personal care. It's about assess eligible care needs. It's not about the kind of additionality that perhaps has been going on within housing with care complexes. So we are actively looking at how do we continue to support, but in a different way.
Yeah, I mean, if I can just say, I mean, I think in terms of the work on falls, I mean, I did raise it at a previous meeting that we need to learn from the exercise that happened at Grahamston House, and obviously that is happening and being moved on, but it also has to be moved on elsewhere, not just housing with care, but also care at home. Because if we're looking at prevention, then getting some kind of activities encouraged for people who are in their own homes is equally important. And I think that's an important thing. Sorry, Caroline, you wanted to come back in?
Yes, thank you, Chair. It was just to provide reassurance to the committee that it's something that I've asked the Care at Home lead to look at in terms of the Care at Home redesign. So he's the main link with our private providers, and members will be aware that actually the majority of care that's delivered, care at home that's delivered, is actually through private providers. About 80% of our provision is from private providers. So we need to look at not just within our internal services, but how do we make sure, no matter what care service is providing the care, that people have the same support and the same approach has been embedded as we take things forward. So it's just to provide that reassurance, Chair.
Thank you, Caroline. Alison?
Thank you. And this is just picking up on a point that Nicola said, because you mentioned when we share some of those findings, we share them across our providers. But again, coming back to Caroline's point, it's not only with care at home that we have a mixed provision, we have that across the whole system. And it's maybe a question back to Marie rather than to you, Nicola. And it's about how do we get that best practice not only from our internal provision, but to our third parties, and how do we support that constant improvement of delivery from the lessons that we're learning into those third party providers, because bluntly, while they may still have that delivery and that operational and that regulatory control, we still face a lot of that risk.
Yeah, I suppose I might come in, and I don't know whether Caroline might come back in. Obviously, through our commissioning lead, we work closely with Scottish Care reps as well, and we have provider forums where we can share learning. So that is promoted, and our Scottish Care rep, leads in some of that work around making sure that training's up to date, and that we're covering the contractual arrangements within our frameworks to make sure that we're taking forward any learning that we have, and we have regular provider forums to share that information. I don't know if that's sufficient, but yeah, I don't know if Caroline had any other comments, but for me, that that's how we're kind of monitoring that and make sure that we've got that shared learning. Thanks.
I don't think Caroline shook her head, so I think there's no further. I think you've covered the issues. I mean, in terms of Burnbrae, I just want to kind of reiterate what has been said before. It's an absolutely superb. It's the first time I think I've seen excellent in any of the inspections, seen a finding of excellent, and I don't think excellent should be handed out too easily. So, and I'm sure it isn't, given what we've had before. So I think the staff at Burnbrae have to be very much celebrated and rewarded. Rewarded is the wrong word, but they would love to be rewarded, I'm sure. But they certainly have done a fantastic job to get this superb piece of inspection. And I think we need to make sure, and that I would like that to be quite a large part of our report to the full IJB as well, and to encourage wider acceptance, wider recognition of what they've achieved, but also of the good practice that we were talking about earlier, because that is what really matters, that we can spread it among all the people that we are providing services for. I will now go back to the recommendations, which are that we should consider and comment on the report. And I think we can agree that we have done that. So can we agree? Yes, I think that's agreed. So thank you very much to everyone for that. We'll move on now to item 8 on the agenda, which is the Alcohol and Drug Partnership Strategic Needs Assessment. And I think we have Phil online to cover that. Sorry, my screen is so far away, it's very difficult for me to see. So when I'm checking with Carly, it's not because I don't recognise people, it's because my eyesight's not good enough. I'm needing binoculars. So
That's
Phil.
okay. Yes. Thanks, Chair. And I can see you, don't worry. So thanks for inviting me along to update colleagues on the strategic needs assessment for the ADP. This has been a significant piece of work that took all of 2025, really. And it's in itself is part of a wider piece of work, a 5-year plan, I guess, to really look at the ADP in Falkirk and to see and to make sure that it is fit for purpose and it is fit to the services that it delivers and commissions are fit for purpose as well, and providing the right support to the right people in the right time. So when I first started in post, there was a very Forth Valley element to the ADP work, and as colleagues know, over the last 3 years, we've done a lot of work to establish the Falkirk ADP with new branding, a new executive committee, new governance structures, new terms of references. We've been looking at the range of subgroups that would sit underneath the ADP executive to be able to make sure that the work that needs to be done is adequately managed and monitored. Those subgroups are continuing to be established as well as we go forward into 2026. So there's a lot of work to do around the actual governance of the ADP and the framework on which it operates. Then we had to look at the capacity of the ADP and make sure that the support team was able to support the executive on making the decisions and advising them on the proper course of action in terms of through the lens of national drug policy and so forth. So there was quite a significant amount of work done on those elements. Now we've turned our attention to understanding the local need, understanding the drivers. The last needs assessment that was done in Falkirk was 2018. Now, so much has happened since then in a national and a local landscape. We've had national policies like the MAT standards, the National Drugs Mission. We've had the new alcohol framework, rights, respect and recovery, the national strategic document there. We've had a lot of shift locally as well, as I'm sure colleagues are more than well aware. And also in terms of drug trends, we've seen powerful new opioids coming into the playing field, the nitazines, which are up to 100 times more potent than heroin that we used to. We've seen new benzodiazepines coming on scene. We've seen an increase in stimulant use, an increase in alcohol use, an earlier age bracket that are using these substances. So there's been a whole range of different things happening over the last few years that we really needed to take cognizance of and be aware of so that we could effectively manage the commissioning work that's coming up. So the needs assessment was commissioned, and that took up all of last year. Let's have a quick. By the way, there was a minor update to that needs assessment in 2021, but again, it's considered too far away really to make much difference to the findings. So what we did find, Figure 8 was the organisation which we commissioned to do this piece of work. Now, Figure 8 are nationally renowned as doing excellent needs assessments. The Scottish Government have used them with the Drug Death Task Force, the National Mission, the SDF, Scottish Drugs Forum, Scottish Recovery Consortium have also used Figure 8. So over the last 15-20 years, Figure 8 have really developed a method to understand local needs through that drug policy lens, both national and local. So they were the ones that were commissioned to take on this piece of work for us, and they did a huge amount of scoping work. They spoke to people with lived experience, people going through the system, people not going through the system, but really should be, people who were delivering the system, so a whole range of different people to try and get a range of viewpoints there. Also family members as well. There was focus groups, there was one-to-one interviews, there were online interviews, there were online surveys, so on and so forth. So as you can imagine, from what I've said there was a lot of evidence and a lot of work gone into this piece of work, and the draft report was presented to the ADP executive in November of last year by Figure 8. It was a really well attended meeting. There was about 25 people there from a range of different multi-agency professions. We had clinicians, we had emergency services, third sector, council, health and social care, so on and so forth. And at that meeting, we made our intention clear that the next step to this process would be to convene a planning group for the ADP to take this forward onto the next level. So to understand and discuss the findings, but then also to discuss how, with the allocation that the Scottish Government provides the ADP, how do we better commission services to provide people who are in Falkirk, who are affected by drug and alcohol related harm? How can we improve their lives and their families' lives as well? So the planning group met for its inaugural meeting just before Christmas, and that was really just an introductory meeting just to make sure we had the right faces around the table, to make sure that everybody understood the outcome that was being sought here, and that everybody understood the timeline we were working to as well. The next meeting will be, it's penciled in for the 2nd of February. I'm trying to get the room sorted out just now, but that meeting will really be bringing the folk into people's journeys through the current system and how we can improve those various different touch points that people may access, and starting to open up this discussion, which over the next 6 months will allow us to develop a range of options to take to the ADP executive on how best to spend the money that is allocated to the ADP and work with services to improve the model of care for Falkirk. Obviously, that will then come to the IJB for approval as well. So we're expecting that to be, I would say, the later half of this year, but not too late because we need to save time for commissioning work. There were some interesting findings from the needs assessment. I've got to say that there was nothing that was completely unknown, which is good. But the evidence that it provided us with was really useful, and it was up to date and current. And it's going to provide us with a lot of evidence and a lot of the ability to do a lot of work over the next 5 years going forward. You can read the main findings yourself because the report includes the executive summary as well. So that's basically where we're up to. I'm happy to take any questions if anyone's got any, and I apologise to the people at the SLT last week because you've heard all this before. But there you go. Thank you very much, Chair.
Thank you, Phil. I think given the seriousness of the alcohol and drug problems in Scotland, which are, it's well known, are fairly high, I don't think you should apologise for giving the same message more than once. I think the message needs to be reiterated until it's properly heard and there is some action. I was really pleased to see that this report is entitled Alcohol and Other Drug Needs Assessment, because sometimes alcohol is forgotten in the statistics and forgotten in the discussion, because it is kind of accepted as so very ordinary. But alcohol harms are a serious concern as well. As well as other drugs. So I was pleased to see that. Before I ask any questions, I'll go to others who've got their lights on. I think we have Alison, then Councillor Flynn, and then Roger. Alison?
Yeah, thank you. An incredibly sobering report to read, and I think it really does bring alive the size and scale of the challenge. So thank you for bringing it today. And that kind of gave me three questions. The first one is, Obviously, as we're going into the planning cycle, the world doesn't stay still. And as you've called out, Phil, that drugs and alcohol, I'm going to call it environment, has changed very much since the last plan. And that will continue to happen. So my first request back to you when you're looking at the planning is to think about how do we future-proof the planning that we've got, and how do we build the systems in so that we are continually doing that assessment. We obviously can't do a full needs assessment like this on an ongoing basis, but how do we make sure that we've got that constant feedback about what's changing and how that reflects in the plan, and how do we build as much flexibility into the system going forward? So that's point one. The second one is about building up on some of the comments we made on the audits, and that when I read this, I thought there's some of this that is very specific about drugs and alcohol, but there's also some of it that feels like it is a more generic theme. And how do we get that join up between addressing the generic themes that will sit as cross-cutting themes in our strategic plan and into the specifics into drugs and alcohol? Because I'm deeply conscious that our staff will be getting lots of messaging going forward, and there'll be lots of change initiatives. So how do we simplify that? How do we build in those common themes so that we can join up the individual functional areas that are looking at it? And the third one is and it was reinforced actually, Phil, when you commented the whole way through this. You said we will spend the money allocated and we will look at how we spend the money allocated. Given the harm that results from this, given the cross-system impacts that it has, is this a subject that we should be opening up into shifting the balance of care type debate? And should we be looking at what is the right funding to put to it rather than what is the allocated funding given the harm that is caused?
Okay, thank you, Alison. Yes, I think it's telling that the report lists population and deprivation at the top of its findings. It's the number one issue, and also refers to early onset. So Phil, could you come back on each of those points, please?
Yeah, absolutely. So all really good points. So the first one about the ever-changing landscape is absolutely right. We have a number of mechanisms by which we in the ADP support team keep ourselves up to date with various new drugs that are coming onto the market and trends that are being seen. We have regular monitoring meetings with our services. We also have a lived experience panel that sits under the ADP that feeds back information to the support team and the executive on various different aspects of drug and alcohol use within Falkirk. We also work with the national team in terms of the radar initiative that is an early warning system for new drugs that are found in Scotland. We work with the ambulance service. So there's lots of different mechanisms by which the ADP team will become aware of different changes within that drugs market. I think that the challenge is then to translate that into making sure that services are able to respond to that. And I think over the last few years, we've seen a perfect example of how not to do that with the MAT standards. We've been completely focused on one aspect of drug and alcohol use, which actually is probably affects one of the smallest amounts of people that attend our services. So our tier 3, what we call our tier 3, our specialist non-clinical service, of the caseload, I think only about a quarter are what we would call MAT patients, that they use opioids to the level that they need to have substitute prescribing. A lot more are using stimulants and alcohol. However, all the focus nationally has been on that smaller cohort. So we do need to design frameworks that aren't substance specific and get to the root of the issue, which is people's dependency and the reason for that, which is often a telltale sign of early trauma. Which we're all very well aware of. And Chair mentioned the point about poverty as well, and poverty is one of the main drivers of drug and alcohol use. If you live in an area of high deprivation, you're 15 times more likely to die from a drug-related death in Scotland as if you weren't in an area of high deprivation. So poverty is a huge driver, and that lack of opportunity within those areas, and also the lack of aspiration for people that live in those areas as well, because they've had life beaten out of them a lot of the time. times, and they've just, a lot of people have given up and resigned themselves to the fate. So you're absolutely right in terms of how we need to make sure that services are fit for purpose and continue to be fit for purpose. The other points you made about the making sure that the policies were joined up, and the fact that the ADP does receive an allocation from the Scottish Government, but again, you're absolutely right, that shouldn't be treated as the only amount of money that is being invested to tackle all of Falkirk's drug and alcohol problems. The ADP is actively working with other agents, other departments within the council, within the health board, within the health and social care partnership, to try to align priorities and joint fund, look at opportunities for joint funding pieces of work, so that we can get basically more bang for our buck on both sides of the fence. So we do need to look at the way we fund these services differently, and we do need to integrate the ADP allocation more into the mainstream HSCP funding structures. We also, in terms of the strategic priorities of the ADP, are trying to link in very closely with the development of the HSCP strategic plan, which is happening this year. There's a new government strategy coming out at the start of this year, which is going to be replacing the National Drugs Mission, which is due to end in March. And we're hoping, well, we're not hoping, we are going to align our local needs, our local strategic priorities to the national strategic priorities as well, if where appropriate, to make sure that there's synergy there. So it's all about weaving and intertwining and making sure that these things work for everybody, not just a specific cohort of people who get marginalised even more because the services are marginalised. I'm not sure if that's hit all the points that were mentioned there, but I'm happy to go over if anything else I missed.
No, that covers everything, and I think I'm looking forward to seeing all of that coming through in both the ADP plan, but also in the wider strategic plan.
I think Marie has also got something to say.
I think probably Phil covered the majority of it. I suppose it was just as well to add that, we're absolutely committed to working with Phil and ADP around, commissioning arrangements and how we might best commission the services that they actually need, through their action plan. So I know we're having early conversations around that as well. So it was just to mention that as well. Thanks.
Thank you.
Okay, thank you. Jim, Councillor Flynn.
Yep, thank you very much, Chair. I would like to maybe, through yourself, Chair, and with Phil, touch on two aspects. I think the report covers a lot of good points, and I'm really impressed with it. And the no wrong door thing is very, very good indeed. But what I'd like to touch on is two aspects. First of all, I think the challenges is getting people who have issues with drug or alcohol or both to come forward and appear and present themselves. And I think that's from memories I've had in the past. That's quite a challenge there. And I just wonder if two aspects here. First of all, if someone has issues, I think it's less likely taking the GPs, for example, they're going to sit on a Monday morning at 8 o'clock or whatever and spend time on the phone saying, look, I need an appointment. Some may do. I guess some people will present themselves to the GP practice or A&E. A&E is a separate issue because obviously, now if I go along to the pharmacy with an issue and say I'd like to speak to the pharmacist confidentially, I'll go into a little room and no one else that's around me in the pharmacy can hear what I'm talking about. I just wonder, Phil, first part of my question really is, with GPs and other places, what steps have been taken if somebody comes in, walks into a GP practice or whatever and say, look, I've got problems here, I need help. Now, I appreciate the GP practices particularly are extremely busy. They don't have the facility. But I think a lot of people would maybe turn around and walk away if there's 3 people behind them listening to this man or woman saying, I've got issues with drugs or whatever. So it's on the confidentiality and getting them into seeing people to start that process to be helped. That's the first question. Hope that makes sense.
Yeah, it does. And I think you're right. The report actually says that there's a gap between those people who need help and those people who seek help. And that's an interesting point there, because what is it about our services that is putting people off accessing them? Is it the accessibility? Are they in the right place? Do people have the bus fare to go into the centre of town to access a service? Do people feel emboldened enough to be able to speak out? Because there's a lot of shame and stigma attached to having a drug and alcohol problem, because it's seen as a moral failing. Despite all the work that we've done over the last 5, 10, 15 years, addiction is still seen as a personal moral failing. So it's very shameful to put your hand up and say, hey, I'm having a bit of trouble with my drinking here. So we've got to try and work with people to diminish that sense of stigma. We've also got to try and make our services and our access points as attractive and as available as possible. And there was a bit of work that I did in another area where we set up an assessment or a triage clinic, if you like, for want of a better name. But it was a really relaxed, informal affair. There was pool tables. There was people got a bacon roll and a cup of tea. It was more of a social, communal space that had that added ability to be able to see and meet people's needs. So you weren't actually going to a building that said local drug project over the top of the door. So it was about trying to make those services more attractive and also in the right place for people as well, so that they weren't needing to find that whatever it is to get the bus fare to go into the centre of town. So there's a lot of work that we can do around the accessibility of drug and alcohol services. I hope that goes some way to answering that question.
Yeah, it does, and you've explained it exactly as I understand it. It is extremely difficult there. I believe David's want to come in perhaps on the primary care aspect.
Yes, I was going to ask David to come in because I think you're making particular reference to GPs and primary care.
If that's okay, Jim, it was on your point. I think as Phil said, what I would be desperate to see is the publics, when they do feel they need help, seeking that help, not through GPs and pharmacies for this issue, but through CGL directly or through other sort of support groups that would then direct them into CGL. And CGL can send people to the GP if there's medical needs, but actually this issue needs to be seen as more of a community issue that people go to CGL for directly. Thanks.
Yeah, no, I understand that.
In the interests of transparency, CGL.
Sorry, Change, Grow, Live, which is our main partner for addictions.
Thank you.
Thank you, Chair. My second point is what I perceive personally as a hurdle, because I believe, and this is only my thoughts, that it's families that suffer. People behind the person that's got a drug or alcohol problem. But I do believe, because of data protection, if I had a family member and I wanted them to get help or somebody to help us, if I phone whoever, and say, look, I need some help with my brother, sister, father, mother, or whatever, there'll be a barrier come up and say, sorry, we can't talk to you. We need the user to come forward and present themselves. And that, I believe, is incredibly difficult. I just wonder how we can overcome that. I don't know the answer to that, but there definitely needs to be, because it's the families in some instances that will be crying out for help.
Yeah.
The person that's using the drug may say we want help or whatever, but sometimes they will deny it, I believe.
You're absolutely right, Councillor. It is a difficult one, especially when somebody is actually going through treatment as well, and the family phones into the treatment provider to try and get an update, that unless that person has agreed to those details being shared, they're kind of stuck. However, what I would say is that the ADP has increased its investment in family support across Falkirk. Good. So over the last 2 years, we've tripled our investment in family support. So we work with Scottish Families against affected by alcohol and drugs, to run support sessions, both group and one-to-one, of various kinds within Falkirk, specifically for the families who may be struggling. Because sometimes, you're right, you might be frustrated that you can't get your loved one into a proper treatment program, but you deserve to get some support besides that as well. So we do provide families a range of support options to help them to cope with their loved one's addictions until such time as that person feels that they want to access treatment programs themselves. But you're right, it is difficult.
Yeah, no, I think so. And I think as well, just to finally just add in my tuppence worth, it's based on my own personal experience many, many moons ago. There's a financial implication because people using alcohol will often spend money that I should have gone to the family to support them. You know, there's a huge financial implication. But no, thank you for that. It's very positive. Thank you, Chair.
Okay, thank you. I think, Roger, you were next.
Thanks. I've been around, as you know, an awful long time, but I'm really pleased over the last 10 years to see what I see as a sort of cultural supertanker here, the culture of just acceptance of the use of drugs and alcohol to a harmful level, to a real effort to try and reduce the harm that's been done by these things, and this change has escalated, but I still see that cultural supertanker taking a long time to slowly turn around, to follow the efforts of Phil and the partnership and etc. I still see people in workplaces talking about lifestyle choices, for instance. I feel like slapping them when they say that comment, and almost a resignation, and this is inevitable. I suppose my plea is that to support staff to come along with this, we need a regular and ongoing update training for all staff connected with in any way with supporting people in families of drug and alcohol, and this training needs to be just scheduled in as regular. That's my ask for the vote to keep up with what's going on.
Thank you, Roger. Do you want to comment on that, Phil?
Yeah, of course. You're absolutely right, Councillor. I think training is one of those things that needs to be repeated as often as possible. The ADP support team has developed its own training package to address stigma, anti-stigma training that is actually on the CPD portal that the council uses, and can be accessed by anybody who wishes to access it. We're also available to deliver bespoke training sessions to whole teams if need be as well. This training is pretty new. It's very unique to us and to the person delivering it, which is one of the ADP officers who's developed this training. The training sessions that we've given so far have been very well received. We've had inquiries from national organisations, Scottish Recovery Consortium, to deliver training to their staff as well, because they recognise the value of the work that we're doing there. So there is anti-stigma training available for all council members. We have also just updated the council's naloxone policy. Naloxone is the medication that is used to reverse opioid overdose. That has not been approved yet by the ADP, so it's not yet live or in place. But part of that policy change will be the introduction of consistent and easily accessible naloxone training for all members of council staff that would require it too, and other training options that we work with the health improvement team on to deliver basic drug awareness training and other such and so forth. So training and workforce development is one of the key priorities of the ADP going forward as well. So I thank you for your comments on that, Councillor.
Okay, thank you, Phil. Yes, certainly.
Thanks, Phil. But I suppose what I'm saying is this needs to be compulsory compulsory training, because until all staff and not just staff directly involved, but if we're trying to change a culture of complacency, all the, I don't want to pick out any particular staff, people in housing, people in home care, everybody needs to have be brought along with this changing culture to try and then bring the society along with the changing culture.
The ambition is to, it was at the start, and we've not yet got to the place where we need to look at this, but the ambition is to make that training compulsory as part of the mandatory onboarding training that all council workers receive. But those discussions haven't haven't taken place yet, so I'm probably preempting quite a lot of stuff there. But that is certainly one of the things that I'd like to look at going forward.
Can I just clarify, is that all council workers or all council workers within a particular section?
This is just an idea in my head at the moment, Chair. Like I said, these conversations haven't happened yet, but the council is absolutely right. These training sessions need to be mandatory and compulsory if we're going to try and change perceptions. Because there's a self-selecting element, isn't there, of applying for training. People only apply for training that they feel that they want to listen to, or they feel might be useful for them. So we want to make sure that everybody has got the option to do this.
I think Sarah wants to come in on that point. Can you add to that?
Well, just really, I suppose, to complement Phil's answer, and we are really pleased to see how well received the anti-stigma training is, but it does complement the other training that has been really successfully received by a number of different service areas in terms of our trauma-informed training. So they really do complement one another and really kind of seeking really the same goals. So really just, I suppose, to kind of underline that we do have different pronged approaches in order to do exactly what Roger is pointing out is much required to ensure that whoever the touch point might be for anybody who requires a service or advice or guidance receives a trauma-informed approach and response, and that there is a level of understanding about what is going on for people who are living in our communities, for any single one of us to be treated well and with respect and with a solution-focused approach. Thank you.
Okay, thank you. Leona, I think you were trying to come in on this point.
I wasn't sure which button to push, but thank you.
It's the middle button. Wait a minute until it goes red. Yep, that's it now.
It was just to say, as part of the ADP exec, that Phil had also discussed about looking at a campaign around making sure that all staff were aware, so maybe on the intranet or, on the council webpage as well, so that the message could be spread about what was available, because it was done a long, long time ago where there was a service directory, because you're right about trying to, for everybody plus the public plus the staff to be able to access and know what is actually available out there. So that was one of the other ideas that we were going to try and take forward. So it was just to try and ease your worries there, Roger, that we could try and get that message out a bit better. Thank you.
Okay, thank you. I think, Alison, you wanted to come back in.
And it was just a quick build on one of your comments there, Phil, which is about it is available to all council staff. As one of the NHS members on the board, I'd really make a request that there's a link back into the NHS side, and that we look at this as a holistic answer rather than just on the council side, because being part of the IJB, that gives you that opportunity.
Thank you. That's a point well made. Those of us involved with the council tend to think too much of the council, and those in NHS likewise on their side. But we need to remember that that both are important. I think a lot of the things that I was going to make reference to have already been covered. But I just wanted to say, I think this is a really important strategic approach to a very major problem. But I do think it's just worth remembering that staff are still working on a day-to-day basis, and there are things going on. And in terms of the issue about shifting the balance of care, I'm aware that there's early intervention activity that goes on in terms of particularly with schools and so on. So I wonder if you could say just a wee bit about that, Phil. Sorry, you're on mute.
I was on mute there. I just turned it off. Early intervention and prevention is one of the key pillars as we move forward that we're looking at planning on. It's I think, to be honest with the committee, it's probably not been looked at in as much detail as what it probably could have been previously. We do have some services working towards young people and young adults in Falkirk. But there's an opportunity there for us to really get our hands dirty with that work. We've worked with the health improvement team in the past to deliver some work within schools. We also just last year was working with the University of Stirling and Liverpool John Moores University to deliver a project called the Illicit Project within some of Falkirk's high schools as well, which was based on an Australian model of harm reduction teaching within the schools, which went down really well. That was an academic pilot which is being evaluated, so it's no longer running as of now, but we're waiting on the findings for that to take it forward. But again, I've also been working with the champs as well, the Falkirk champs, to look at their needs, what are care experienced kids' needs in terms of their encounters with drugs and alcohol, and what the reasons why they might want to use those as well to support to cope with daily living. There's a lot of different aspects to the young person's experience on that, and this is one of the key areas where the ADP needs to work with colleagues. So we work very closely with the Children's Strategic Planning Partnership on a lot of these works, just to try and make sure that there's, one, no duplication, and two, that any funding that goes towards any pieces of work on early intervention and prevention are combined as well. So there's a partnership approach there definitely to be had, but again, this is another one of those pieces of work that will be expanded on over the next few months as we enter the planning stages.
Thank you, Phil. The other issue that I wanted to just make reference to is at 412 in the report, page 257, you make reference to the fact that fewer people from Falkirk are accessing residential rehabilitation treatment. I wonder if you could say a bit more about that. Is that about the availability? Is it about the whether there is capacity?
It's not about availability, it's not about funding, it's not about capacity, and it's something that we need to understand better. I would say it's probably about how the process is delivered within Falkirk and across Forth Valley. So it's the NHS Forth Valley specialist clinical team, substance use service, that operationally manage the ADP's residential rehab placement program, and the way that is done needs to be looked at, in my opinion, to make rehab more accessible and more attractive and talked about more within Falkirk. There's no barriers to rehab in Falkirk. This was actually a question that was asked of me at another meeting from a councillor, but there are no physical barriers to access it. It may be something that isn't spoken about enough, so people aren't aware of it as an option. But also, if we look further on in the report, it does say that there's a lot of people, there's that gap I mentioned before about the people that need treatment and the people who access treatment. So maybe this is just about a rationalisation of numbers and a kind of economies of scale. If not as many people in the area are accessing treatment, then not as many people in the area will be accessing that type of treatment neither. So I think it's something that we need to be looking at very, very closely. And I would prefer to see residential rehab as an option laid on the table at a person's first encounter with a service, as opposed to something that's mentioned maybe down the line. But again, it's an expensive option. and there's also one that would need to have careful consideration from all partners, not just an ADP officer trying to push forward an agenda. So this is something again that we'll be looking at within the planning group over the next few months.
Okay, thank you, Phil. I don't see any further questions coming forward. And I think the number and range of the questions that you've had here today tells you what a huge interest there is in this issue. And I think it's important in terms of encouraging those people who do need a service to take up that service. Part of the issue is about having more conversations about the issue and making it more acceptable to talk about it. So I hope that we've done some of that here today, and good luck to the Alcohol and Drug Partnership in taking that forward over time to come. I also think that obviously, when the new government strategy is brought in, it will be important that the Alcohol and Drug Partnership does adapt procedures and policies in relation to that. But I do think it's important to look at the way in which you have done it, which is start from the need base, assess the need first, and then let that lead your strategic approach. So I think that's right. The national strategy is going to be all very important, but we must meet the need that is there on the ground. So thank you very much, Phil, for your presentation today and your answering of the questions. And thank you to all who've been involved in this. The recommendation is simply to note your progress to better understand the drivers. And I think you have been making a huge amount of progress to better understand the drivers. And we look forward to receiving further reports when you're designing an improved model of care. Everyone agree to that recommendation?
Agreed.
Thank you very much. I think given the time, it might be advisable for us to have a short break, to say 10 minutes. Is that adequate for people? Yeah. Okay, we'll have a 10-minute break now, and then we'll come on to locality planning. Okay, everyone, welcome back. Here in the room, we've put jumpers on because it's not very warm today. So I hope that wherever you are, you're quite warm. We're going on now to item number 9 on the agenda, which is the Falkirk Health and Social Care Partnership locality planning. And we have, I think, Gordon Mackenzie and James Patterson, I think, to deal with this. Are you going to start, Gordon?
Yeah, I mean, James is going to make some introductory comments to the paper, and we'll be here to answer questions. And just to let you know, in the last few minutes, I've started to have some IT problems, so I will be with you as long as I can. Hopefully, it won't crash on me. But over to you, James, please.
Thank you very much, Gordon, and thank you, Chair. So, as mentioned, the report in front of you today is an update regarding the locality planning process ongoing within the Falkirk Health and Social Care Partnership, and the work that's been ongoing since September 2024, when the IJB endorsed the approach for the development of locality plans for our 3 locality areas, and this involved a phased approach. All 3 plans have now been approved. The Central Locality Plan was approved by the IJB in January 2025, our East Locality Plan in June 2025, and West was approved last month. So all 3 plans are now within their implementation phase. And figure 1 in the report provides a summary of the development process for the 3 plans and oversight being provided by the locality delivery groups as we move forward with implementation. At 4.9 within the report is some feedback from some of our partners that have been involved in the locality planning work, who have reported improved networking, signposting and collaboration across sectors. 4.10 also outlines some challenges that have been identified and mitigating actions where appropriate. Attached to the main report is a high-level summary on progress within the delivery plans for East and Central, and work is underway to prepare and convene the delivery group to monitor implementation of our West delivery plan. The intention is to provide regular updates on these plans at future strategic planning group meetings. And when the strategic plan objectives have been agreed, locality plans will be reviewed for alignment to maintain a golden thread linking them to the strategic plan and IJB, but whilst retaining their unique local value. Similarly, performance indicators for each locality plan will be developed to align with our new strategic plan. Work will be ongoing within our locality delivery groups to explore and identify ways that we can evidence impact on communities, and also to continue to focus on collaboration, networking, signposting and progressing work streams within respective delivery plans. Other key points to note is whilst our plans primarily focus on adults, we have representation on an oversight group from children and justice colleagues who are collaborating with them as they embark on a similar approach, and it's important that these plans tie together locally. Likewise, we have close links with the Community Planning Partnership, which has its own locality planning process, and we continue to build on those relationships too as we move forward. So thank you. That was a quick, brief introduction, and we're happy to take any questions that you may have.
Thank you, James. Then do we have any questions or comments? Roger?
Thanks. Sorry about that. Thanks, James. The report says one of the challenges was resources, and clearly if there's not flexibility of resource use to fulfil the locality plans, it's going to be quite a challenge. Do you want to say a bit more about that?
Yeah, what I can probably add is in terms of that aspect when saying resources, it's understanding the resource within staff and capacity as well to help with movement of the delivery plans. And I think we're trying to be flexible with that within our delivery groups in terms of when we're asking for updates and progress on what work's ongoing, trying to acknowledge that where there maybe is risk and barriers based on their capacity, that we're raising that within our locality steering group meetings and looking at ways at how we can improve or work together to try and address that. So that was on that section within the locality planning report was specifically discussing about resource capacity in terms of staff and time to work towards the delivery plan and the actions within the delivery plans, Roger. So I hope that answers the question that you're asking there.
Okay, thank you. We have David next.
Hello. Thank you very much, Chair. And really, it's just a question in terms of how well the plans are being understood and accepted by the local communities, and how well they're using the services as a consequence of the introduction of the plans.
From what I gather within our delivery groups, David, and thanks very much for the question, from the staff and from the partners who represent our service users and people within our communities, I think from their experience, they're saying that they have been well reflected from service users. They really see the value in it, and also partners are trying to share the locality plans with them as well and making them aware of that. In terms of access and services, I don't have that information, but discussions are ongoing within the delivery groups as well. When that is raised at our delivery group meetings or is raised as a concern or raised as a challenge, we look to address that and discuss that within our delivery groups. But certainly from the partners and colleagues and representation we have in delivery groups, they seem to be well received by the community. And certainly from the support from the engagement that we had to develop delivery groups too, we tried to ensure that those communities were involved within the locality plans as well.
Thank you, James. And the locality plans are clearly fundamental in terms of our aims of early intervention and prevention. And so they're very, very welcome from that point of view. I wonder if you could say a wee bit more about the ways in which you're going to be monitoring the impact of that and how it is actually meeting the strategic aims of the partnership.
Thanks, Councillor Hannah. And as mentioned in the introduction, we're still reviewing that within our delivery groups as well. But in terms of monitoring the work in the delivery plan too, it's asking for some qualitative information that's coming back from the leads that are taking on that work, so we can review what is the information that they are providing to us and what can we look at to take forward. But certainly that is work we're hoping to do within the delivery groups, is identify how we can monitor and how we can address the impact and have better information available on how we can do that and look at what is improving within the communities. So right now, in terms of monitoring, it's taking that qualitative information and activity summary within the delivery plans and reviewing that and looking at what we can do to improve, and certainly focusing on that monitoring input as well.
Can I just add to that, Chair, to say that obviously we want to have that link with the strategic plan, the new strategic plan, which will be developed in the course of this year, to make sure that the locality plans are aligned to that. And from that, the intention is to have performance indicators that we would then monitor and work to.
Thank you. Just in the interests of following on from Tom. Yeah.
Yeah, thank you very much, Chair. Gordon slightly stole my thunder there, but that's always welcome. I think it's just important to emphasise the kind of interrelationship, but also relative autonomy in relation to the strategic planning process. So in many respects, there's of course an alignment, and rightly so, an alignment between our overarching strategic objectives of the partnership, which will be expressed in the next year in relation to the strategic plan, and the localities and how they are aligned with those strategic objectives. But there's also a good balance in there of them also reflecting more localised objectives as well, and feeding that up and through that whole process. So I suppose it is just to acknowledge the important relationship there, whilst not to diminish the locality plans as anything, as just being the delivery arm of the strategic plan. They will themselves gather and engender a quite powerful vehicle for local voices and local citizens' requirements.
That's a good point, Tom. Thank you. Stephen?
Yes, thanks. Yeah, probably Tom's answered that, because I just had seen the comment about the challenges being the voice of lived experience. So I know there's an organisation called Vox Scotland. They're quite small, but they provide that advocacy for people with sort of severe to moderate to severe mental health issues. But yes, I'm just keen to find out about how we include that voice of lived experience. But I suppose Tom has started to build on that. So thank you.
Thank you, Stephen. I think that's right. You need to start from what is local and what people's needs are. It's a bit aligned with the discussion we had over the ADP. We need to look at what the needs are locally and what people actually are going to want. One of the other themes that is interesting for me is what we discussed in relation to a previous report about reducing the number of falls. And we've been talking about doing it in homes, but it also is important in the community. And many of the community centres and sports centres have chair yoga, they have walking football, they have a number of activities that people can get involved in that can have this impact. And I think it's really important that we remember those areas of possibilities in terms of improving health outcomes. Anyone else got any comments or questions? In that case, we have reviewed and commented on the progress. Can we agree that recommendation? Agreed. Okay, we will move on to item 10 on the agenda, which is the Clinical Care and Governance Management Group report. And I think this is you again, Nicola.
Thank you. Yes, so this report gives an update from the Clinical and Care Governance Management Group, and it's set out in its usual format. So just jump into section 4, where we're looking at our standing agenda items. You can see the detail there in terms of some of the items that were discussed. In relation to care assurance visits across all of our services, there were largely no concerns, but I felt it was important to highlight that during one visit to a district nursing service, they returned a limited level of assurance. Just to give assurances to committee, this was in relation to clinical supervision arrangements for staff, and that actually in relation to the quality of care that was delivered to service users, there was a substantial assurance rating returned for that. There is an associated improvement plan in place, and that will be monitored. In relation to adverse event reports and care inspectorate notifications, you'll note that there was no unusual trends were highlighted, but we'll continue to monitor these. Looking at adverse event and learning reviews, the adverse event review group during the last reporting period reviewed 6 new cases. 5 of these related to pressure ulcers that developed within the community setting, and 1 was in relation to a death of a person in prison who was receiving end-of-life care. The adverse event review group did note an improvement in processes and access to interventions when compared to a previous similar case, so that was a piece of good news there. One of the adverse events, so one of the pressure ulcers, was escalated to the Shared Intelligence Group, which is chaired by the medical and nurse directors for consideration for further actions, and a local management team review has been commissioned for this. That will encompass the manager of the local service doing a deeper dive into the holistic care that was delivered to that service user and looking at the adverse event that occurred. Not only will that learning then be shared locally, but a report will be formulated and it will be brought back to the Adverse Event Review Group and back into Clinical Care Governance Management Group for that wider dissemination of learning. In terms of external inspections, the group heard an update in relation to the HMIPS inspection report for HMP Glen Oakle. However, there is a separate deep dive on the agenda just after my item, so I won't go into detail on that. And we've already heard earlier in the agenda in relation to the Bunbury Care Home Care Inspectorate report. The management group also considered a report from the Adult Support and Protection Lead Officer. Well, we considered 2, but the first report was in relation to adult support and protection data sets. The lead officer shared that there's been quite a significant increase in referrals since 2021. So there was a 116% increase in referrals and 136% increase in inquiries with investigative powers. The lead officer did also highlight that of these referrals, 56% did not meet the 3-point criteria. And that is highlighted that there's a training requirement which the lead officer has taken forward with other key colleagues. One other thing in relation to this report that the lead officer had highlighted was that adult support and protection activity is led by a council officer, and there's going to be a piece of work exploring council officer numbers across all of the teams to respond to these high levels of activity. The second report that we considered from the Adult Sport Protection Lead Officer was in relation to interagency referral discussions. So these discussions they can take place for people who are referred under adult support and protection, and they are tripartite discussions. So they are have representation from health, from social care, and from police. And the piece of work that's led by the lead officer for adult support and protection looks at the quality of the IRDs, as they're called for short, and they're sort of audited against a scale of quality. So the updated report that we received showed that 63% of IRDs were rated as good or better quality, which was an improvement. Take that back. So this report showed that 88% were rated as good or better, which was an improvement on the previous report, which was 63%. Apologies for that. With 56 were rated as very good, which is the highest rating that they can have. Moving forward, the management group has asked that the lead officer also includes information in terms of timescales for IRDs. So we want that assurance that IRDs are undertaken in a timely manner, and also to explore the quality of ASP referral handling for cases that don't proceed to IRD. So what is the quality like for the other cases? The last report that we heard in relation to that meeting was from the mental health lead, which was in relation to embedding trauma-informed and responsive change. So the mental health lead shared or reiterated, I suppose, that this was an ambition across Scotland to develop trauma-informed services and workforces that can recognise the impact of trauma and adversity and respond in ways that prevent further harm, support recovery, reduce inequalities and improve life chances. So the lead had explained that there was initially a programme set up in 2018 and that was refreshed in 2023, and it was rebranded the National Trauma Transformation Programme, and it was to reflect a shift away from just wanting to raise awareness to actually driving implementation and embedding trauma-informed practice within our day-to-day work. So there was some evidence, a report done which highlighted evidence in relation to impact if services are trauma-informed, and that had highlighted that the service users experience improved wellbeing, reduced distress and presentation and better overall outcomes, and it also highlighted significant benefits from staff. It's highlighted as well that trauma-informed leadership is a critical driver in achieving and sustaining meaningful system changes. And the group heard that actually there are 3 trauma-informed champions appointed to represent and lead trauma-informed practice across Falkirk, and they are detailed in 4.24. So the mental health lead did share the variety of training and development opportunities that are available, and shared that there's a trauma lens walkthrough tool that is a key resource that can be used in identifying opportunities to improve not only your environment but your way of working to become more trauma supportive. The mental health lead did share that actually we've made great strides across Falkirk and that there's been significant numbers of people that's been engaged in this project, but we took the opportunity to ask all CCGMG members to share this report widely with teams to try and keep the momentum going. In relation to risks, so there was a previous risk that was identified in one of the previous reports in relation to staffing levels within the social work teams. So the head of community services and the head for specialist services have mitigated that risk by increasing staffing levels through recruitment into vacant posts and realignment of work. And I just wanted to highlight that part of the realignment of work has seen the development of a dedicated social care occupational therapy team, which will provide a focused response for those waiting on an OT assessment and intervention. They'll be undertaking a test of change, and the Clinical Care Governance Management Group will be updated on the progress and impact of this. Again, one of the previous risks that was previously highlighted to committee was in relation to a care home who were graded as weak by the Care Inspectorate, but that risk is now reduced. The care home was revisited by the Care Inspectorate and they had recognised some improvements that were made, and they regraded the home as adequate. Just to say, even though the home has been regraded as adequate, they will the ongoing support from both the chart team and the NHS care home support teams will continue to improve that quality there. And the third risk is just, we've spoken about this previously, but in relation to transitions of care, in particular in relation to communication upon discharge from hospital, that has been escalated through NHS clinical governance routes, and I've asked for this to be considered. I've asked for this to be considered as a work stream on the upcoming refreshed safety collaborative, so actually we can have a focused effort on this. And then future steps, so we are undertaking a review of the subgroups just because of the restructuring that's taking place, so this is an opportune moment for us to do that, so we'll update committee on how that progresses in due course. And happy to take any questions, thanks.
Thank you, Nicola. I think this is an important report in that it gives us the assurance that the management team is thoroughly addressing some of the key issues that it should be addressing. So it is important. I see Stephen has his hand up. Stephen?
Oops. Thanks, Chair, and thanks for that, Nicola. I suppose just putting my Forth Valley head on, because I sit in clinical governance there, I'm fairly new to that committee, still getting my head around it. So I suppose my plea would be a lot of that good work that you're doing, and in the partnership, I'd like to see more of that coming through into our clinical governance. I think it's a different space. Obviously, we've got the medical director and the nurse director in that space as well. So I just wonder what your views were in that, about how we, not just for this IJB, but I think probably CLACS as well, which also sit on it, my plea to them. I just like to see a bit of a tighter relationship there.
Yeah, I see Gail's coming in. There are conversations happening in terms at exec level in terms of how we strengthen those links, and whether, you know, I would take a similar report into the NHS governance committee, but I'll let Gail come in because she's much closer to the conversations than me.
Gail?
Yeah, so as you said, Stephen, it's really important we've got that golden thread across all aspects of our system around clinical and care governance. So the comprehensive report that Nicola now brings to this committee also goes into the Chief Officer's Public Protection Group, and it also goes into the Clinical and Care Governance Working Group in NHS Forth Valley. And we are having conversations about how we make sure that the appropriate level also comes through to the Clinical and Care Governance Committee within NHS Forth Valley. So those conversations are ongoing. I think it's really important as a member of that committee, you feedback what will be helpful to help inform that.
Okay, thank you. Alison?
Thank you. And it's really just about the test of change that I wanted to come in on. And I'm really supportive of the test of change that is undertaking. But it did raise a question in my head about the number of tests of change that we have, how they all fit together. And as a board, how do we get to the point where we can see that big picture? Because this then starts to come back into what does this do to your operating model? What does it then do feeding into your strategic plan? And how do we get that coherent picture of almost a hypothesis that you're testing and what the strategic implications of that will be? Now, it might not be an issue because there might not be that many, but if there's a lot of them, that then becomes a different challenge. And it is also a challenge then to make sure that the right hand and the left hand know what they're doing and everything is moving in the same direction.
Yeah, I think in terms of tests of change, we've got our heads of service who oversee all of that, and then that gets fed into SMT, SLT. So there is that bird's eye view in terms of everything that's happening and how it's all interlinked. In terms of the specific test of change, I don't know if Caroline wants to come in relation to that, but yeah, I suppose just to offer you that assurance that as a senior leadership team, we do have that bird's eye view of all the tests of change that's happening, and they are aligned to strategic priorities, and we're aware of not burdening staff, I suppose, with too many changes. Okay, thank you.
Does Caroline want to come in? I don't see her hand up. Yes?
Yes, I'm happy to come in, Chair, if that's okay. So just in reference to the test of change that Nicola was highlighting there, that was in response to issues around waiting lists and waiting times for people that are waiting for functional assessments. So we took the decision that we would centralise, as a test of change, centralise the OTs that were all sitting within the social work locality teams. And they would have oversight from actually an OT team manager and really work through that waiting list, but also look at the approach and how they can improve our offer around that, but also how do we link with OTs across the whole system and take some of the learning around that and also remove some duplication. So that's part of the work that they're being tasked with right now. What's going to happen is the output of that then we'll report to our SLT with a recommendation about how we would take things forward. And there'll be a number of options that we can look at around that, whether we come up with a different model or whether we continue with a centralised approach. But also we need to look wider than that and be clear around when citizens come into the system, how are we responding and how are we providing that consistent approach. So hopefully that provides a bit more context around this specific test of change.
I come back and I press again.
Didn't need to press again.
And it was just to say thank you, Caroline. And I think the fact that you mentioned that it's not just only looking at this in its own boundaries, but also what the implications are across the rest of the system, that's the piece that gives me the confidence, because every single one of these will have unintended wider consequences, and they will have the kind of butterfly flapping its wings, and it will have impact elsewhere. So as long as when we're doing them, we're looking at that wider impact, that kind of does give me much more confidence. So thank you.
And I think that's an important point, and we are conscious that because there is so much work going on in terms of transformation, there are a number of tests of change pilots going on. It's all very positive because it's about looking forward in terms of saying how can we improve the services, but it's also a bit scary when you're trying to change everything all at once. So it's important that there is that overall governance and that overall the overview. Going back to Stephen's point about the NHS and the importance of taking some of this forward within the NHS, I was conscious that in terms of the trauma champions, we don't have anyone focusing on education. And given that it really is important to focus on early intervention and prevention, I wondered if there's any thought about looking at schools.
Yeah, it's a good question. Martin is much closer to is Martin still online?
Are you still there, Martin?
Oh, Sarah might be able to come in.
Sarah?
Yes, convener. So the trauma champions really do take care of all of the Health and Social Care Partnership and the Council and NHS Forth Valley. So they're really there to support implementation of trauma-informed approaches across education, across social work, housing, right across the full gambit. So there is attention paid to that. I could certainly ask for some specific information to be provided to you around the education input.
Thank you. I think that would be useful because, as I say, we're all about early intervention and prevention. We need to focus on that. And I'm aware of the work of the champions, which is very, very valuable. Does anyone else have any questions or comments? No? If not, then the recommendation is that we consider and comment on the updates provided, and I think we have done that. Are we agreed?
Agreed.
Thank you. Okay, we'll now move on to item 11, which is the deep dive into prison healthcare, which Nicola referred to earlier on. We didn't get caught up in the prisons because we'll now move to Leona Paget to hear about the deep dive into the prison healthcare situation.
Thank you very much.
I am on red. I have provided the paper, which I'm sure that you've all had time to read, and I've got some slides which Cheryl has put up for me. Thank you. So this is a deep dive into prison healthcare, and it covers all three of our prisons, which is HMP YOI Polmont, HMP Glenocal, and HMP YOI Stirling. Can I have the next one? So the executive summary. Extremely positive inspection findings for HMP Glenocal Prison Healthcare team, and we just put in the follow-up inspection action plan 2 days ago to Health Improvement Scotland and HMIPS team, and it's come back and there's not going to be any follow-up. So they were very happy with our action plan, although saying that our next inspection is due this year at some point for HMP YOI Polmont, because they're on a 4-year rolling programme, so we never get a break. Overall, strong ratings against 9 of the 9 health and wellbeing standards. Health and wellbeing standard 9 is the one around health for the whole of the inspection. We are the only health team in Scotland currently to be rated good, which is the top mark that you can get. The highlights from HMP YOI Stirling and HMP YOI Polmont have been included. So the 3 prison teams are through to finals for the Team of the Year for RCN 2026, which we find out if we're going through to the final part at the end of this month. The committee is asked to consider and comment on the report, and there's no formal direction required at this stage. So the inspection by the HMIPS and HIS in February 2025, the report was published in November 2025, and we were noted for having strong, compassionate leadership for an ageing and firm population, and our age range at Glenocal, currently, well, our oldest is an 85-year-olds, but we have from 21 years old in Glenocal up to 85 just now currently. In Stirling, we have 18-year-olds, and I think our oldest is in their 70s, and Polmont is a very complex population where we have remand convicted women, adult men, and young offender men as well. So right now, prisons are really struggling with overcrowding and staff shortages, and we are on the 2nd early release batch just now, currently with the tranches going on until the end of April. It was going to be the end of February, but it's been extended slightly to try and help with the overcrowding. But on the whole, especially in Glenocal, men are being 2'd up, which means 2 per cell when it should be 1 cell. So that causes significant challenges such as boredom, more drug use, more assaults, staff assaults, etc. So going back to the inspection examples, we were noted as having 20 examples of good practice for the healthcare team, and I won't read them all out, but they covered everything from neurodevelopment to good communication to strong leadership and quality improvement projects. Thanks, Cheryl. We have been working on a project which, although the project is ended as such, as in the money that came through as a grant, it was in partnership with Strathcarron Hospice, which went on for 18 months looking at frailty in HMP Glenocal. And this project has continued where we are still doing the frailty screening. The screening tool was changed and it's being used. That was to bring down the age by 10 years, because if you're a prisoner, your health and mental well-being comes down by those 10 years compared to being outside in the community. So we have paid for the licence for that frailty, the Edmonton frailty screening tool, to be changed to be 50 years plus. And it's now being used on a national basis across all of the Scottish prisons. And we have had 3 prisons come out to see what good work has been done in the recent months. So recognised as a model for the Scottish prison estate, which is excellent. We, for Polmont, the full inspection was done in August 2023. And we showed significant improvement from poor to satisfactory. And this was all around the time of the 2018 high-profile suicides, which there's still scrutiny and a lot of audit and ministerial attention to currently, and there's a ministerial accountability board that's been set up that Gail attends, as myself and Ross McGuffey. The challenges are the rapid population changes that we've had, especially in Pullman, because they more than doubled the numbers due to bringing in adult men. And currently they are putting in bunk beds into one of the halls on 2 of the levels to increase that population even more in the next couple of weeks, month. So unfortunately with SPS, they're the ones who make the decisions and can make the changes overnight. So that will be our next huge challenge, because we're already struggling with the extra 270 men that have been brought in the last year or so. So temporary over-recruitment of nurses has really helped with our sustainability, and this very much depends on government support, and NHS Forth Valley has been helping out with the over-recruitment as such, and Falkirk Health and Social Care Partnership, but we need some consolidation and what's going to be our steps for the future to maintain that level of funding as well. Non-urgent mental health waiting list in Pullman has, well, across all the prisons actually, but mainly in Pullman, has tripled, and urgent action is required in Pullman just now because we are not managing to get through what we deem as non-urgent mental health referrals, because we're having to focus on the urgent mental health referrals. And this is all around when the Scottish Prison Service and the Justice Committee agreed to all the recommendations that was made by Sheriff Collins. They changed all admissions in Pullman have to be put on 72 hours of what is Talk to Me, which is observations. It's the suicide strategy for SPS, which has increased our mental health workload considerably, because we can have up to 40 caseloads a day when you've only got 4 to 6 mental health staff nurses trying to work through that those daily tasks every day. It's been hard. It has been hard on the team. Next one, Cheryl, please. For HMP YOI Stirling, achievements and inspection, we were awarded the National Unsung Heroes in November 2025. And with the teams doing so well at being nominated for things such as the Unsung Heroes, that we've got the RCN Awards coming up, it's a huge pat on the back for the amount of work that the health teams get through. And the health teams aren't just nurses, as you'll be aware. It's everybody it's a small NHS behind those 4 walls, 4 fences as such. So it's everybody from admin right up to my psychiatrists, including AHPs, nurses, everybody. So that's been really positive for the team. The inspection in 2024 showed that we had good support for vulnerable women, use of speech and language specialists, and in 2025 they reopened a female unit in Carstairs Hospital, the State Hospital, which is the first time since 2002, which has helped for some of our high secure, very unwell mental health patients that we have, because there was no high secure mental health beds in Scotland at all until then. Satisfactory overall rating, 16 examples. I hate the word satisfactory because it just sounds satisfactory, but it's just the second down from the top. 16 examples of good practice and 8 recommendations for improvement, which was very good. And again, our leadership and governance praised for our vision and support. And that, again, is not just my managers below me, but everybody above me as well. The Committee of Prevention of Torture delegation also came out and visited HMP Stirling, Bella and Lilias. And Bella and Lilias are community outreach units, which are under different health boards. One's Dundee and one's Glasgow. But the governor in charge at Stirling is in charge of all 3. So they came, that it was part of their 10-day visit, and they spent a day and a half with us at Stirling. It was unannounced, and they noted that there were some complex needs not fully met, and the need for more suitable environments for certain women. But within HMP Stirling, they were very happy with the environment that we provided, but they were meant more with external, so more mental health resources in the community before the women come to prison and for when they're going out of prison, as well as the state hospital and the extra beds for high secure. Ongoing assessment and workforce flexibility required. So they were aware that there's a lot of resource being put into HMP Stirling when the prison was opened 2 years ago, be 3 years this year, sorry. And that resource is not equivalent to our other 2 prisons. So Stirling is in a very good position as in resource, but in the last year, because of Pullman and Glenoakle, the strains in there, we are having to be very flexible and utilise our staff in the best places possible to ensure that our clinical risk is as low as possible with the actual resource that we've got within the 3 prisons. Cheryl, next. So a business case has been drafted, and it has been around for quite some time now, and it's been reviewed again recently, and it is around, obviously, resource. We have 3 national prisons within the Falkirk Health and Social Care Partnership, and approximately 8% of our prisoners have an address that belongs to Forth Valley. So it is very hard on our health board as such and our Falkirk Health and Social Care Partnership, where the resource is quite minimal compared to the number of people that we have to look after and their outpatients. And it's all about their health and well-being. So we are at the highest ever prison population in Scotland. That's since it's been recorded. And currently we're sitting just over 1,400 prisoners across our 3 prisons. And every subject that's been covered that I've heard so far today, from alcohol, drugs, to health and well-being, to physical health, to mental health, dental health, podiatry, psychiatry, is all what we have to maintain a high level of standard within our 3 prisons. And I am appreciative of being brought along to meetings such as this to try and spread the word of how much work does go on. So non-mandatory training is on hold right now because we're staffing issues due to vacancies, sickness, and in the recent couple of weeks we have lost quite a few staff that are moving on to new jobs, promoted jobs, which is always going to be the case. That's me, Cheryl. So risks and next step. Our mental health non-urgent referrals are not being seen. That's on the corporate risk register because it is a clinical risk just now because I don't have enough staff, and it's not easy just to bring any member of staff because we have mandatory training for SPS, which is 2 days minimal, and it takes 3 to 6 months at least for new staff to even try and settle into the routine. Our increased workload from Talk to Me placements, mainly around the 72 hours in the MOS. So MOS is the drugs observation that prisoners get put on when they've been overdosing or using too many drugs, usually at the weekend. So we can go between 14 on MOS to 40 on by over the weekend and Monday, and that carries on through the week, depending on how well they are. Sometimes they do end up in the acute hospital if they've been unconscious for a long time. And as Phil had alluded to earlier on, the drugs that they're using on the whole are through vaping and spice, so there is no antidote. We use naloxone, but if it was just opiates and benzos, we would be, our job was a lot easier 10 years ago, but now it's drugs that we don't know what we're dealing with, and nor does our emergency department colleagues, so we just have to try and keep them alive. So ongoing need for funding, as I've touched on, workforce planning, because we're constantly battling with recruitment and retention, even though we've done really well over the last 7 years, and over-recruitment has helped considerably, but put me into overspend as well. Equalities and impact assessment is required because our population needs are forever changing, and it's not through our direction, but it's through Scottish Prison Service, where they are having to fill whatever gaps there are throughout the 17 prisons in Scotland. And it has put on a huge amount of workload to our teams within. That's me, Cheryl. So in conclusion, continued focus on maintaining good practice and implementing improvements, and we're very proud of what the healthcare team can get through, and we're very, very busy. I've put out the follow-up inspection, but that's because I've done my slides just before I was told by his there is going to be none. They're very happy with our action plan and they're happy with the work that has gone on. And then they also told me that the Pullman one will be due this year and I'll get 6 weeks notice. And then a committee to review, comment and support resource requests. And that is me. And I believe we've got a video to show you, which is just a couple of minutes from one of our patient relations team who works with our service users and for some of their service user feedback. And then I'll take any questions and answers. I'm sure you won't have any. This is Jessie Ann Malcolm, for those who don't know her. Glad it's you, Cheryl.
While we're waiting from that, I think we need to say, well done in terms of the inspections that there have been, and that's a lot of hard work going on there under difficult circumstances. I'm just filling time, really.
Put a smile on a resident's face and give them hope for the future, I feel I've done a good job. Hi, my name's Jess. I work for NHS Forth Valley. My role is public involvement and community engagement, which includes the prisons that we provide healthcare for in Forth Valley. On a weekly basis, I update my lists within the 2 prisons I work in, and I make a point of going over to the hall that they are resident in, and I meet with them in an interview room on a one-to-one basis. I want to make sure that they feel safe, that they know how to access all healthcare provision within the establishments. I spend a lot of time when meeting with a resident explaining what the role of the healthcare team actually is. So I will explain to them the role an advanced nurse practitioner carries, a role that a mental health nurse carries. The healthcare we provide within the prisons is unique, as in it is very much patient-centred. For example, on occasion I met with a resident who had broken his glasses and had been suffering terrible headaches. So I offered to take the glasses back to the healthcare centre where the optician is based, and he very kindly agreed to meet me at reception at the end of the day and collect these glasses for this specific resident. And lo and behold, these glasses were mended and brought back the very next day, because he appreciated that he wouldn't be able to turn around a new set of glasses as quickly because there is quite a waiting list. There's not another prison in Scotland has someone like myself engaging with patients on a weekly basis, but the number of complaints that have been put in by residents has reduced dramatically, because I've been there to help and signpost. Since I've been doing this work, I've realised that there's no right and wrong in life. no one can be judgmental. No one knows how fortunate they've been with their upbringing. If I can put a smile on a resident's face and give them hope for the future, I feel I've done a good job.
Thank you. I think we should all take that as our motto. If I can put a smile on a service user's face and give them hope for the future, I think that's our job, isn't it? Thank you very much. Does anyone have any questions they want to come forward with, or any comments? Oh, everyone jumping in. We have Alison first.
Thank you. So it's really picking up on the challenges that you raised, and how do we address them. So the first one obviously is the mental health non-urgent waiting lists. So how much of a risk is that, and how critical is that that's addressed, and what is the barrier that's stopping it being addressed? And then the second piece is around your recruitment retention challenges. They obviously will have knock-on effect into some of that service provision, but again, I'm sure you will be doing everything you can to address those. But what would make most difference to you to be able to address those challenges, really?
Thank you, Alison. So for the retention recruitment, it is I know everybody asks for resource, but we are overspent every year, and Marie and Gail and Ross have been very supportive, and we've been at government level, but to have that recurring money coming in instead of having to have Scottish Government that just give us non-recurring money every year to cope with the overspend, that would take off so much pressure, because then you know what you're working with within. I think as a service, because we can't just say, oh, can Ward 2 send us 2 staff today? We just don't have that ability, so we always have to consume our own smoke. So it is that long recruitment retention programme, and that's why it has worked so well and so efficiently, and the stats in the paper of how much we've brought that retention down by. It's really because people want to come and work in prisons. Prisons is a good place to work. It's complex, it's challenging, it's Marmite. They either love it or you hate it. But because every day is different, we have managed to really encourage people to come along, such as mental health OTs, SLTs, and they all love working there. So it's not a case that we can't get people in like other nursing jobs or any other jobs. It's just about one has to go out before we can bring in any more. And then I couldn't even say, well, if you were to give me 50 staff tomorrow, I wouldn't be able to accommodate it because we haven't got enough room within the health centres. So it's about having that real balance. But if we could have recurring money, not funny money, that would be huge appreciation. But what we really need is around that 2 million mark, and I could spend more, because we have to do everything from trauma informed to therapeutic to admin to data, etc. So that would be a huge bonus. And what was the first part? Sorry. Oh, about the non-urgent. It's very critical, because for every death, whether it be natural or suicidal or whatever, in prisons, it's a fatal accident inquiry. Mm-hmm. So we're under that constant scrutiny. And the ministerial accountability at board that's been pulled together, and with Angela Constance leading that, is about reform to prevent avoidable deaths. So we're always going to be under that scrutiny and audit, and don't want anybody to die in prisons, but people are dying in prisons. I have currently in Glenocle 8 men on do not attempt resuscitation because they're at end of life palliative. So for the non-urgent mental health, it's always going to be critical. Everything in the prison is always going to be critical. It's always going to be at the top of my list. But again, I need mental health nurses and resource to be able to come in and deal with all the extra case conferences, caseloads. And Ross and Gail are trying very hard with a cross-party national meetings to make sure that health and justice talk, because that is also a big step to trying to help, because justice does make the decisions and then health have to carry on to understand. So when those decisions are made, there's no money coming down extra for our resource, but there is for Scottish Prison Service. So if we could get that to come down as a proper collaboration partnership, that would be hugely helpful as well.
Okay, thank you. That's really helpful.
I think it would be useful at that point. I'd like to bring Marie in to talk about the budget and the funding, and Nicola also wants to come in to on that point. I think Marie first, is that best?
Yeah, I suppose just to confirm, although I'm not directly involved in the development of that business case, that's our NHS finance colleagues that have been working on that. They are appealing. It's been prepared since 2023 around that overcommitment. It is being funded on a non-recurring basis, on an annual basis, but there isn't that recurring funding as yet. There isn't that commitment. And I know Gail has been meeting with Ross and others and appealing to Scottish Government. I don't know whether Gail might come in and mention that work around that as well. Thanks.
Gail, do you want to come in at that point?
Yeah, so just to confirm, there are regular conversations at executive level within NHS Forth Valley and between the Director of Finance, Chief Executive and myself with Scottish Government to hopefully help to make the funding that's available recurring. I think that's important from a number of perspectives, as set out by Leona, but also if we know the funding is recurring, that allows us to employ permanent staff, which is quite often more efficient to the public pound than having to react to issues. So it's about getting that onto a sustainable footing. Obviously, there's lots of changes at the moment in terms of prison population and reaction to try and manage that, which also contribute to the level of turnover in terms of the prison population, which creates additional burdens on the staff teams as well. So we're really hoping that we can get to that position where we do have that agreement around the budget available that will be coming through. And as Leona said as well, the population in the prisons, most of that population is not Forth Valley population, it's from all over Scotland. And I think that's really important to recognise. Also, just to reference that obviously it's a delegated service to Falkirk IJB, but NHS Forth Valley, in recognition of the situation, did agree at the beginning of this financial year to underwrite the financial risk around this, so we don't have to have that concern at the end of the year, where's it going to come from. So I think that's really, really helpful from an NHS Forth Valley position.
Thank you. Nicola?
Yeah, thanks. I suppose it was just to add a little more context in terms of the local actions that's been taken. So lots of what Leona's described, I suppose, is out with our control. We're waiting on decisions at a sort of government level. But in terms of recruitment and retention of staff, there's been lots of local actions that's taken place to bring that turnover rate down from 20% to 10%. So Leona underplayed it a bit, but Leona and the team have done masses of work in terms of advertising posts in a unique way, using videos, increasing opportunities for student nurses to come in and do placements to expose them to that environment. Some of our graduate nurses in prison healthcare settings are then going out to universities to speak to undergraduate nurses to bring them in. Also, what we've done as well is we've looked at skill mixes across our sites. So Glencoe was a particular hotspot, so we've changed the skill mix and created more senior posts, which offer support to staff, but also offer that career progression as well. So it sort of assists with the retention. And then the final thing that we've managed to do is secure, Leona's touched on it, is secure quite significant over recruitment for posts that were not funded for, but actually we took it to the NHS SLT, a proposal to say we're spending money on supplementary staff anyway to keep our services safe. So actually, can we use that overspend to over-recruit into substantive staff? So I think all of these actions together have stabilised the situation as much as we can. That's the actions that's within our control, but the other actions, as Leona and Gail are speaking about, are being progressed. I just thought it might be helpful to add that wee bit of context.
Thank you for that, Nicola. Is that adequate? Or yes?
It does, and I guess it is. I think it's one of those things that we can do what we can do, and then we can escalate what we can't do. But making sure the risk of the elements we can't control is really visible, I think, would be critical for us as a board.
Thank you. Stephen? Sorry, just a moment, Stephen. I think Marie wants to come back in.
It was just to add there as well that obviously Gail mentioned that underwriting for this financial year. I have been highlighting it as a risk in the budget papers that are coming forward, and I'll be including it in the sensitivity analysis that's coming forward in January as well. So just to confirm that as well. Thanks.
Thank you, Marie. Right, Stephen.
Thanks, Chair. Listen, commend Looney and the staff. I mean, you consider where we were not that long ago, and in the back of the two FAIs, what the job that you've done there is absolutely fantastic. It's being ex-police and also sitting on the board of this management authority. You know, the prison system's complex. It's riddled with inequality. We have no control over sentencing policy or the prison population. It's a fragile and unstable system. I think what you've done is absolutely fantastic. But just to take on some of those points, you know, if there's anything we can do, I'm aware of the national conversations round about, you know, supporting that business case. That strategic alignment between health and justice, it really needs to continue. I suppose for me, there's a lot of stuff that we can't control, and Nicholas just pointed out what you're doing to try and control it on the controllables, and I think it's fantastic. I suppose in terms of the potential controllables, are that non-urgent as it stands waiting list, because we know that people on that waiting list are going to become urgent. And I had a conversation with Ross on the back of the meeting with the families in the back of the FAI, and I think there's potential to introduce a distress beef intervention system within prison. It wasn't built for the prison population, but I think that is something, and I'm happy to take this off the table and have a chat with you, and I've had a chat with Ross in relation to this as well. I think if you could get that into the prison service, it would really help staff and the prison population to manage that non-urgent element. And my final point is, like, you know, how it's not really an issue for us in Falkirk, but it is in some respect, because we take in, you know, 8% of our prison population comes within the Forth Valley area. So it's like, how do we encourage the prison service to really start looking at this in a wider capacity? Because I think there's a moral and ethical duty to try to manage these things nationally, because the substantial inequality that you see within the prison service is stark. So, but again, what a brilliant bit of work, and thanks again.
Thanks very much, Stephen, and more than happy to have a conversation off table around what you suggest. Always open to new ideas.
Excellent, thank you. Any other questions? I had one. You made mention of, because of the demand for prison spaces, they're bringing in bunk beds into corridors.
No, not corridors.
Not
actually,
corridors.
So
I
it's my
misunderstood
term of
then.
speech for prisons because of the column landings. So but each landing has got the cells. So in each cell they'll put bunk beds in. So where there's been single beds, they'll put in the bunk beds, so that 2 people. So we call it either 2 up, and then some cells will do 3. But right now they're bringing in more adult men, and from other prisons. At first they were suggesting to take from Glenocle, so that Glenocle could be filled with more sex offenders, because half of Glenocle's sex offender, half is serious organised crime mainstream. And then Pullman, as I said, is a mixture: young offenders, convicted, untried men, young men and adult women. So that's the most complex population of any prison in Scotland right now is in Pullman. Glenocle, you've got 750 men, half being sex offenders, half being your serious organised crime mainstream. And then Stirling is first night for every woman in prisons, first night custody, unless you come from north of Inverness, then you go to Grampian. But Cottonville, Stirling is a third is very unwell women that there's just nowhere to go, and it's mental health, and they hold 90 to 114 within there. But we have to keep the spaces down because you've got admissions every night, because Pullman and Stirling are admitting prisons, Glenocle's a transfer in prison, so it takes from other prisons. But it's just, I could talk forever about prisons, and as Nicola says, I always underplay what work has gone on because I've lived and breathed it since 2012, since we took over NHS took over the healthcare, and from shutting Peterhead to bringing them down to always the population changes, but they are filling every possible space they possibly can. So for Glen Oakle, capacity is 680, but we hold 750. And we've gone higher than that. So that's why they're doing the early release tranches, which in the amount of workload just to get people even back out to the community for 80% of them, I hate to say, tend to be turned around and come back into us. So it only gives us that very short gap and that very short space. So, but it's some form of trying, I guess, and we have to take everything that we possibly can just to try and ease some of the burden.
Okay, so just remind me that you said there are 1,400 prisoners in total, and how many staff are there providing the health care for these prisoners?
So from my band 3s right up to my psychiatry, I have head count 150 across the 3 prisons, which sounds a lot. But if I was to go full-time equivalent, I think I'm around 130.
And it may sound a lot, but you have to recognise that prison population is a very high level of health issues.
Yeah. So I have a
and a high level of complex health issues.
Definitely. So I've got admin team, primary care team, patient relations team, mental health team, addictions team. I have AHPs, so it's a proper multidisciplinary. Then I have we have a service level agreement with the state hospital for some of the psychiatry and some with Forth Valley psychiatry, so that we've got that mixture. Have psychologists, podiatry, MSK physio, and opticians. What else do I have? Public dental services. So if you can think of a GP practice hybrid, because we have to do a lot of secondary care as well, because we're dealing with what we call codes. So unconscious, code red, code blues, many suicide attempts daily. So it's also, you're always on the line of how much you want to talk about how good the care is that we provide within prisons, because we're always going to have that kind of kickback where psychiatry, I'll get you seen by a psychiatrist within days. If you're outside, it's a lot longer. So I'm always, most probably why I don't overplay what we do, but I'm always open to being open and honest with small groups.
And it's obviously it's a 24-hour-a-day service.
For nursing, no. It's a Monday to Sunday. From Monday to Friday is 7:30 in the morning till 8:30 at night. Weekends is an 8 to 5 shift, because that's the same as prison day shift, so we have to fit with them.
Right.
And the open and up time and lockdown, and then night time it's out of hours, and it also use Lothian custody police nurses as well. So we use our out of hours nurses to come in to help with palliative care, but that's a very recent progression that we have only had to use a couple of times, thankfully, just in the last couple of weeks. So that was for an end of life, and to make sure that we can put in place comfortable, dignified deaths, because most of our patients, and I call them patients because as soon as they come into healthcare, they're patients, have to have a compassionate death, and they want to die that's their home.
On that very sad note, I want to say thank you very much to you and the other staff for all the work that they do. Very, very impressive. You said you could talk all day about the work that you do in prisons. I think we could ask you questions all day as well, but I'm conscious that we better move on. Thank you very much for all you do, and congratulations on the way in which the difficulties that you're experiencing are being dealt with, and we hope that some of the resource issues can be resolved sooner rather than later.
Thank you.
In terms of recommendations, I think it's fair to say we have considered and commented on the report. Thank you to one and all. for all the very useful questions that have come up, and to you for all the answers. And the final item on the agenda is simply in terms of our report from this committee to the Integration Joint Board, to highlight the key issues that we have dealt with here today. And I always ask Gail to listen carefully. It's useful to have someone who's not engaging so much to take the notes. And I wonder if you could maybe give us an idea of what you have highlighted, and people can add to that if there are particular issues they want to see brought forward.
Thank you, Chair. So as you've said, this is a standard report that we compile, which takes in the link between the PAC committee and IJB. So I suppose the first question the last two committee members is, do committee members feel they're assured by the information that's being considered today? That's a yes or a no.
I think that's a yes, certainly from me. Anyone else otherwise minded? No, I think you can take that as a yes.
Okay, so again, it's for the committee to decide what they would like to highlight to IJB. As per usual, I'm going to make some suggestions for consideration, but it's the committee's decision, obviously. So I've got 4 items that I would suggest might be helpful to highlight to the IJB. So first of all is PAC considered the updated strategic risk register and sought assurance around specific actions being taken to mitigate the identified risks, and noted the ongoing review of our strategic risk register will seek to ensure that the progress and impact of specific controls are more clearly reported in the revised format. So the next one is PAC considered recent national reports and inspections and commended the team at Burnbrae Care Home for the recent very positive inspection. The committee discussed themes for improvement coming through a range of inspections and received assurance about the process in place to ensure that wider learning in respect of the areas of good practice as well as for areas for improvement. And PAC considered and discussed in detail the complexities and interrelationships across the community and services identified through the ADP Strategic Needs Assessment. And PAC received assurance about prison healthcare through a deep dive which covered the outcomes of recent inspections, including examples of good practice that were identified and some of the challenges currently being faced, including as a result of overcrowding, diversity of need in the prison population, required changes in practice around mental health assessments, and challenges in relation to sustainability and recurring resource. So that's again some suggestions, but over to you if there's anything else or any changes you'd wish to make.
I think that covers the main points, although I would have liked to see you saying a little more positively about Burnbrae and about the prison service, to congratulate the staff and to highlight a wee bit more about some of the good work that is going on. That would be my only comment. Does anyone else have anything they would like added in or changed? Alison?
It is just maybe being a wee bit more explicit about the risk around the prison element and the financial implications, given it will come through in the budget elements. I think it would be helpful for the wider AGB to understand those.
Yeah, I think generally sorry. Do you want to say something about that?
I was just going to say, so I will be adding that to the budget paper that's coming at the end of January for IJB anyway. So absolutely, it's it is good to express that we've considered it here as well, but it absolutely will be part of that update that's coming to IJB anyway. Thanks.
Okay, Roger.
Just a second, what Alison's just said there, that it sounds as if the prison situation is holding together by the fingernails. So well done. But yeah, I think we need to do better than just holding together by the fingernails.
So more praise for staff in prisons and Burnbrae, and more emphasis on concerns about resource. Is that fair comment? In that case, I will say thank you to all for your attendance and attention, and wishing you a good weekend when it comes. It's not far away now. and I will see you all next time.